Alright, let's resume with congenital cardiac defect associations. So, it kind of drives people a little crazy when they talk about chromosomes. There's all these numbers and letters, and especially when someone doesn't explain it. So, let's talk about it. First of all, chromosome 22, there is a long and a short arm. So, the long arm is denoted by Q, and the short arm is denoted by P. P for petite. Some French guy wanted to name the short arm P because petite in French means small. So, of course, someone else decided to name the long arm Q because it was the next letter in the alphabet. True story. So, we have chromosome 22, long arm, which is Q. Now, what is the 1, 1, or 11 for? So, this first number that follows the letter indicates where this bad boy is. The first one indicates that it is region 1, and the second one tells us that it's band 1. They just did this because when you look at chromosomes, there are different densities of DNA, so it appears like there are bands, like you would see on soccer socks. Deletions in this area of your chromosome 22 are really bad because they code for very important transcription factors that are crucial in the signaling that occurs between the endoderm, mesoderm, and the neural crest cells. So, endo and meso interact with the neural crest cells, and the transcription factors encoded by this region of chromosome 22 are responsible for mediating how often those signaling molecules are made. And this interaction is very important in the development of the pharyngeal arch system. 22q11 or 22q11 syndromes present with abnormalities including the persistent truncus arteriosus, tetralogy of Fallot, because there is abnormal neural crest signaling in these syndromes. With abnormal neural crest signaling and movement, you get a constellation of symptoms including abnormal or absent descent of the aorticopulmonary septum. Remember, the aorticopulmonary septum was the septum that divides the truncus arteriosus. It has to descend and twist in order to create a normal outflow tract for both the aortico and pulmonary outflow tracts. Remember, the aorticopulmonary septum develops from the conotruncal endocardial cushions. Down syndrome has a particularly high association with these endocardial cushion problems, but why? I would tell you just to memorize it, but the chances of anything else being able to be crammed into your brain right now are slim. Studying for step 1 is a tough time, so let's understand why. This is a particularly important region of chromosome 21 to consider. So, chromosome 21 has a very important area that codes for cell adhesion molecules that are directly responsible for these endocardial cushions to be able to bump into each other and fuse and remain fused. So if you lose this area of chromosome 21 for any reason, or there's some abnormality in Down syndrome, chromosome 21, then there's abnormal cell adhesion that is particularly important for endocardial cushions to fuse and grow into each other. So think about this. In the embryology section, you learn that the endocardial cushions are masses of proliferating tissue that form in the atrioventricular and conotruncal regions, right? So atrioventricular is obviously between the atrium and the ventricles, and conotruncal is the conotruncal area, where it's the cone-like area of the truncus arteriosus. So if these are not able to correctly form, then you have gaps that allow communications between the left and right atria and ventricles, potentially creating an ASD and VSD. Another one that we need to consider is rubella. Congenital rubella is particularly bad because the virus likes to infect endothelial, vascular smooth muscle, and myocyte cells of the developing heart in particular. So without correctly functioning vascular smooth muscle cells, you lose the ability of these cells to proliferate, and you need the ability of vascular smooth muscle cells to proliferate to close septa. Vascular smooth muscle cells are also important in the signaling to fibroblast for closure of the ductus arteriosus. So, there is malfunction of vascular smooth muscle cells, then you get a patent ductus arteriosus, and that is one of the classic things seen with the congenital rubella syndrome. The pulmonary artery stenosis is also associated with inadequate development of the endothelial cells and vascular smooth muscle cells within that vessel. So you also have pulmonary artery stenosis. And you get a endocarditis-like presentation due to the infection of the endothelial cells and the myocardium. Now, Turner syndrome we just discussed, and that is a very high yield association, especially because they can tie in the reproductive chapter. It is classically associated with a bicuspid aortic valve or coarctation infantile type. This is not yet completely understood. Now, what about Marfan syndrome? We know this one, right? This is an incredibly high-yield section of biochemistry that will pop up in your cardiovascular anatomy and physiology, pathology as well. Well, we better know our Marfan syndrome because it ties in cardiology with biochemistry. And you could prevent someone from dying if you knew that they had increased risks of aortic dissections, because you would be able to recognize that they have Marfan syndrome and could potentially present with the signs and symptoms of an aortic dissection. Now, individuals with Marfan syndrome have mutations in what gene? The fibrillin 1 gene, right? This makes a fibrillin 1 protein that is crucial for the maintenance of elastic tissue, because it is actually a scaffold. So if you can imagine, here is our fibrillin, and tropoelastin is added onto it like a scaffolding. So this fibrillin 1 protein acts like a scaffolding. So like if you were building a house, it's like your foundation to add tropoelastin. Tropoelastin just means before elastin, and then there's some cleavage of the tropoelastin to form elastin. The fibrillin is also an incredibly important inhibitor of TGF-beta, which is transcription growth factor beta. It binds TGF-beta that is floating around in the extracellular matrix. Just for clarification, not all people with Marfan syndrome have a fibrillin 1 mutation. Some can also have a mutation in the transcription growth factor beta receptor, so it will be actually overactive. Doesn't matter really. Just remember that you need the fibrillin 1 protein to act as a scaffolding for holding the extracellular matrix together, particularly elastin, and also you need the fibrillin 1 protein to bind and inhibit transcription growth factor beta in order to keep it from going crazy and sending continuous growth signals. Now, what would happen if we had excessive TGF-beta activity? So if we know what transcription growth like factor beta does, then all we have to think about is what would happen if we had way too much of it. Well, first of all, what does this do? It is a potent signaling molecule that stimulates fibroblasts. Now, when you stimulate fibroblasts, what would you expect to happen? You would get a bunch of collagen and proteoglycans. It also inhibits the matrix metalloprotease enzymes that are responsible for breaking down collagen. So therefore, we get even more collagen and more extracellular matrix components. So why is this in the cardiology section? Well, these fibrillin molecules are in incredibly high amounts, not only in the ciliary sonule of the lens and ligaments, but it is particularly found in the media of the aortic arch. So this tells us why these people are particularly susceptible to lens subluxation, because they have way too much proteoglycans, collagen. Remember, proteoglycans retain fluid. These will have very loose lens supporting structures. They will subluxate or fall out of position. And then also they'll have very lax ligaments. They can literally bend their fingers back on themselves. And then they're at risk for aortic dissection because they have very weak aortic arches, particularly due to the defect in the media. Let's further illustrate this because this is a concept we need to know about aortic dissections anyways. So think about the aortic arch. There's an intima, a media, and the adventitia. There's a layer of endothelial cells that compose the intima. Separating the intima and the media is the internal elastic lamina. Separating the media and the adventitia is the external elastic lamina. So remember, there's 3 layers. In between each layer, there's an elastic lamina. Now we're focused on the media. The media is highly rich in elastin. Now what happens if we have abnormal elastin because the scaffold that it builds itself on is abnormal, which is our fibrillin 1 protein? Well, you will have a very weak media, which means that you increase your risk for dilation of the aortic valve ring, which is the root of the aorta. And this can lead to aortic regurgitation. If you think about it, here's your arch, here's your root. If this dilates out, then you have increased risk for aortic regurgitation. So, we spent a lot of time on Marfan syndrome, and this is important because we need to know that this is a risk for aortic regurgitation. So, in addition to this cardiovascular manifestation, the uninhibited activity of TGF-beta can also lead to excessive creation and deposition of irregular weak tissue, particularly of the mitral valve, which leads to mitral valve prolapse. And that is why you see mitral valve prolapse in these patients. So again, Marfan syndrome, incredibly high yield. It is absolutely necessary to know, because anytime a test examiner can incorporate biochemistry into a test question, you better believe he or she will. The last incredibly high yield association is that of an infant of a diabetic mother. Remember, infants of diabetic mothers are predisposed to transposition. Now why? Well, we know that transposition of the great vessels is most likely going to be caused by an abnormal twisting of the aorticopulmonary septum, as in it did not occur at all. Can anyone tell me why this happens? So, an infant of a diabetic mother, they have chronic high levels of glucose. They will have very high levels of insulin in response to that high level of glucose. Hyperinsulinemia can actually cause abnormal growth factor signaling within the developing heart. Remember, insulin is a powerful growth hormone itself and can interfere with the normal signaling that occurs between cells during the development of the goniotruncal region, and it can interrupt the rotation of the aorticopulmonary septum. And that's why you get transposition, because hyperinsulinemia is a very dangerous situation for a developing heart. Now, let's continue with hypertension. This is an incredibly important section. Blood pressure will be a value that you look at for every single patient for the rest of your life. Every single patient, literally, even the radiologist, reads the initial history and physical and looks at the vital signs. Okay, that might be a lie, but anyways, you better know this stuff either way. So, hypertension is defined as systolic blood pressure of greater than 140 systolic and diastolic of 90. Okay, great. That's easy to remember. We need to understand some of the risk factors and why. We know that as we age, that's a risk factor. Now why? It is because we have increased stiffness of our arteries, which means that they are less compliant. Remember, compliance equals the change in volume in a vessel for a given change in pressure. If you decrease the ability of the artery to expand for a given pressure or volume, then you decrease its compliance and you will raise the pressure for a given increase in blood volume. Example, you put something into a vessel, it wants to descend, but it's not very compliant. For that given volume, you increase the pressure very much. So, if you decrease the ability of the artery to expand, as you age, you have decreased compliance, and that leads to an increase in your blood pressure readings. Now, what about obesity? Obesity leads to a hyperinsulinemic state. High level of insulin can activate the sympathetic nervous system, which can cause elevations in blood pressure. Now, smoking cigarettes is a really terrible idea. Smoke impairs the ability of endothelial cells to produce nitric oxide, and you get increased levels of reactive oxygen species because there's increased reactive oxygen radicals within the tar of the cigarette. And this can actually oxidize LDL that is deposited within the vasculature. And we all know that oxidized LDL is like a dinner bell for macrophages to come over. They bind the surface of macrophages, and the macrophage is activated. Macrophages then start releasing a ton of cytokines. We will further discuss this in the atherosclerosis section. Just be aware that cigarette smoke can be associated with hypertension. Obviously, genetics is a rather obvious one here. If someone in your family has a history of hypertension, you can guarantee that you will be at increased risk as well, with the greatest risk being African Americans, probably due to the increased sensitivity to sodium. They require a much lower amount of salt to activate tubuloglomerular feedback. Remember, that starts at the macula densa and ends with activation of the renin-angiotensin-aldosterone system. 90% of hypertension is essential or primary, which is yet to be completely understood. But in your mind, you need to remember that for someone that has essential hypertension, these patients have an increased sensitivity to salt. That leads to activation of the RAS system, and there's also an increased activity of calcium channel depolarization due to increased sodium influx into cells, particularly vascular smooth muscle cells. The reason for secondary hypertension is chronic activation of the RAS system secondary to renal disease or something such as hypoperfusing the renal system in which the RAS system is chronically activated.